I just want to say good morning and thank you for allowing me to be here. This is a dream come true for me, it really is. And I want to say thank you especially to my wonderful and beautiful CIs. And I also want to say thank you to everyone that I worked with that acted like a substitute for my CIs. And thank you to everyone for answering my questions. So my presentation is on treating severe traumatic brain injury, and I'm going to give a brief synopsis of vagus nerve stimulation in rats. So patients with traumatic brain injury rely on healthcare providers, especially physical therapists, to provide them with accurate care and information. However, there are some healthcare providers that have inaccurate beliefs and misconceptions about caring for traumatic brain injury. For example, there's a cross-sectional study that shows 20.3% of nurses had misconceptions about unconsciousness, amnesia, recovery, and rehabilitation after TBI. The objective of this presentation is to explain how we can provide optimal care to TBI patients and to ensure that we are providing the best education to the patient and their family. Traumatic brain injury is a structural and physiological disruption caused by blunt trauma, acceleration or deceleration forces, and exposure to a blast event, causing a period of disorientation, confusion, changes in consciousness, or amnesia. From most common to least common, TBIs are caused by falls, motor vehicle accidents, struck by or against events, and assaults. There are 1.7 million TBIs that occur each year in the United States with 288,000 hospitalizations. 29,354 of those hospitalizations occur in California alone. Unfortunately, 80 to 90,000 of those patients will have long-term disability. There are different types of TBI. There is a primary injury that disrupts brain tissue and function at the moment of impact. The other type is a blast injury caused by translational and rotational acceleration of the brain, causing compression and shearing from the explosion. Primary injury can be broken down into further subtypes, including focal injury, diffuse axonal injury. A focal injury is damage to the brain by collision forces on the skull, causing compression of tissue under the cranium. A coup focal injury is one in which tissue damage occurs at the site of impact with the cranium, while a contre-coup focal injury is when tissue damage occurs with the cranium opposite to the site of impact. A diffuse axonal primary injury is when rapid acceleration causes widely distributed damage to the axons. Shear, tensile, and compressive forces are placed on the brain when this happens. A grade 1 axonal injury is when a lesion is created on white lobar matter. Grade 2 lesion is when a grade 2 axonal injury is when lesions are created on the corpus callosum. And a grade 3 axonal injury is when a lesion is created on the rostral, lateral, dorsal brainstem, as well as lesions on the same structures as grade 1 and grade 2. So here's a list of signs and symptoms that could occur secondary to a TBI. They include hypoxic ischemic injury, intracranial hematoma, soft tissue injuries, fractures, spinal cord injury, spasticity, decorticate rigidity, cerebral rigidity, muscle atrophy, peripheral nerve injury, internal organ injury, DVT, heterotopic ossification, pressure ulcer, chronic pain, and pneumonia. TBIs will have cognitive changes that could include changes in mood, memory, executive function, judgment, initiation, attention, and problem solving. You'll also see neuromuscular changes through observation of gait, balance, sensation, weakness, spasticity, and contraction. So oftentimes TBI includes damage to the frontal lobe, and when this occurs, you have frontal executive dysfunction. This could cause problems with problem solving, impulse control, self-monitoring, short-term memory and learning, attention, and speech and language functions. Frontal executive dysfunction also includes personality changes. Patients will do things that they normally wouldn't, such as make verbal utterances, physical actions, snap decisions, poor judgment, stimulus boundedness, irritability out of proportion to the stimulus, affective instability, unsuitable affect, and apathy. This is a long list of symptoms that occur specific to severe TBI. You all can go over this list on your free time. So the physical therapy assessment begins once the patient is medically stable. But the assessment frequently is unable to be completed within the first session, so usually it is ongoing for the first few treatments. Close communication with other members of the multidisciplinary team can be extremely beneficial. So on occasion, 2 or 3 therapists from different disciplines can be useful. Before starting a physical therapy assessment, it is essential to check with the patient's medical team and the patient's chart to ensure that the patient is medically stable, and to also monitor the vitals when performing assessment and treatment. So it is important to make sure we remove distractions from all the senses. Therefore, keep the noise level low, close the curtains, and turn off the TV to reduce any visual distractions. Before starting, perform the assessment as soon as the patient demonstrates spontaneous movement and shows an improved level of consciousness. So make sure you be polite and considerate to the patient, address the patient by their name, and speak at intervals. For example, you can say such phrases as, "John, I'm going to move your right arm now," immediately before doing it. And always work under the impression that the patient may be able to hear you and understand you, even when they're unable to respond. Once the cognitive level of the patient has been established, it is important for the therapist to adapt their communication style. If there's significant speech impairment, simplifying questions that require a yes or no will be helpful. Also, if the patient is able to understand spoken language, establishing physical gestures that represent a yes or no is crucial. And this can usually be done in conjunction with the speech and language therapist, and oftentimes the family can help provide information on communication. Once you finish with that, early stages of recovery involve assessing consciousness or behavior. And this can be measured by the Glasgow Coma Score scale and the Rancho Los Amigos levels of cognitive functioning. Outcome measures to assess activities of functional mobility include the functional independence measure and the function in sitting test. The functional independence measure assesses the patient's level of disability and also determines how much assistance is required to carry out activities of daily living, with 18 items graded on a 7-point ordinal scale ranging from total assistance to independence. Assessing body structures or function can be effectively measured by the modified Ashworth scale. The modified Ashworth scale measures spasticity on a scale of 0 to 4. If the patient shows no increase in tone, they get a 0. If they show a slight increase in tone, they get a 1. If they show even more increase in tone, but the limbs easily flexed or extended, they get a 2. If the limb is significantly increased in tone, they get a 3, and if the limb is rigid in flexion or extension, they get a 4. Later stages of recovery include the same outcome measures, but they also include outcome measures that assess higher functioning activities such as coordination, balance, and task analysis. Thanks to the development of advanced or intensive care treatments, brain damaged patients have a much higher rate of survival. Therefore, the prediction of long-term functional outcomes are important to determine the care and resources needed to be targeted at those with the most to gain, and to provide families with reasonable expectation for the recovery of neurological function. The Glasgow Coma Scale is the most common clinical scoring system used to assess the level of consciousness after TBI. And it also classifies the injury as severe, or less than 9 points, moderate, 9 to 12 points, or mild, 13 to 15 points. It is an easy to assess test, it is reproducible, and it is an important prognostic factor in determining outcome predictions that may influence treatment strategies. It assesses eye-opening response, motor response, verbal response, and each category is graded based on how the patient responds to each. Rancho-Los Level of Cognitive Functioning Scale is a common clinical tool used to assess how a patient is recovered after TBI. The 10 levels in the scale help to determine when a patient is ready for different phases of rehab. Each level describes a general pattern of recovery with emphasis in cognition and behavior. Level 1 through 8 describes a lower cognitively functioning patient, while levels 9 and 10 describe a higher cognitively functioning patient. In level 1, the patient gives no response and requires total assistance. To elaborate, this patient gives no or absolutely no observable change in behavior when presented visual, tactile, auditory, proprioceptive, vestibular, and painful stimuli. Level 2 patient elicits a generalized response and requires total assistance. Level 3 is when the patient gives more of a localized response, still requiring total assistance. But this patient demonstrates withdrawal or vocalizations to painful stimuli. This patient will turn towards or away from auditory stimuli. They will even blink when a bright light is flashed in their eyes. They will even follow a moving object within the visual field. And they respond to discomfort by pulling tubes or restraints. And they also respond inconsistently to simple commands. A level 4 patient is the confused or agitated patient. Now they require maximal assistance. This patient demonstrates an alert, heightened state of activity. They will attempt to pull on tubes or restraints. They'll even try to crawl out of bed. They may perform motor activities such as reaching, sitting, or walking without any apparent reason. They are unable to cooperate with treatment efforts, and verbalizations are frequently incoherent and inappropriate. Level 5 is the confused, inappropriate patient, still needing maximal assistance. This patient is alert, but they're not oriented to person, place, or time. They show brief periods of sustained attention. They have severely impaired recent memory, confusing the past with the present. They're unable to learn new information, and their verbalizations are frequently inappropriate and confabulatory. Level 6 is the confused, appropriate patient that now needs moderate assistance. This patient is inconsistently oriented to person, place, or time. They're able to perform highly familiar tasks in a non-distracting environment. Their remote memory has more depth and detail than recent memory. They are beginning to become aware of appropriate responses to self, family, and basic needs. They require moderate assist to problem-solve barriers when achieving a task. They require supervised self-care and maximal assistance for learning new activities with little to no carryover. And they're unaware of impairments, disabilities, and safety risks. So when taking the history, it is important to document the cause of the TBI, the date, and any complications. Make sure you determine the patient's current Glasgow Coma score and what the Glasgow Coma score was upon admission. If the patient is severely cognitively impaired, little subjective information will be attained unless there's family that can help. Not only can the Glasgow Coma score help in determining a prognosis, but knowing how long the patient was in a coma can help determine recovery outcomes. Better recovery outcomes tend to occur in patients that were in a coma for less than 1 week versus longer than 2 weeks. Risk factors predicting poor outcomes in patients 65 years or older include respiratory failure, pathological pupillary response, higher injury severity scale, and a midline shift of the brain greater than 15 millimeters. TBI is actually a risk factor for development of Alzheimer's disease, Parkinson's disease, chronic traumatic encephalopathy, and post-traumatic epilepsy. Patients at level 1, 2, and 3 may not qualify for rehabilitation services initially due to their inability to consistently participate in a therapeutic regimen. At these levels of cognitive functioning, treatment typically focuses on prevention of immobilization and disuse complications, weight shift management and repositioning, passive range of motion, and mobilization of respiratory function, including aggressive pulmonary hypertension. A randomized controlled trial found increased neural responsivity to vocal stimuli after familiar auditory sensory training in patients with disorders of consciousness 29 to 170 days after the TBI. For patients in a persistent vegetative state or coma post-TBI, bimodal or multimodal stimulation should be used early and continue to be used until more complex activities can begin. So these are desired outcomes for level 1, 2, and 3. We want to make sure we're maintaining joint mobility, reducing any secondary impairments, reducing contracture, ensuring proper joint mechanics, preventing skin breakdown, improving circulation, improving functional postures, increasing the level of alertness, and promoting movement and learning. So the ability to follow directions and concentrate is significantly impaired at level 4. The patient may not be able to actively participate in a therapeutic program. However, if physical therapy is indicated and appropriate, the goals and interventions should be uniquely tailored to the patient based on signs and symptoms, as well as physician recommendations. Readiness for rehabilitation does not generally occur until level 5, because by then the patient will give more consistent behavioral responses. But here we have a list of recommended ways to facilitate treatment in patients at level 4. Make sure you follow the patient's lead within safety limits. You can even ask the family for familiar music to be played during therapy to help calm the patient. Reassure the patient that he or she is safe. Create a calm, soothing environment. Use a calm, soothing voice and keep the noise level low. provide frequent rest breaks and change activities often. Soft hand mitts are sometimes provided for patients who are at risk for pulling out tubes. And sometimes we have to physically restrain the patient in case they're at risk for hurting themselves due to agitation. Here are a list of desired outcomes, which include increasing physical function or motor control, postural control, and tolerance to positions or activities. Make sure we're managing atypical muscle tone, ensuring skin integrity is intact, improving or maintaining joint integrity or mobility, and we want to make sure we're educating family members and caregivers on the condition of the patient and the plan of care. It is important to keep in mind that patients with level 5 and level 6 TBI have impaired attention, balance, and walking, which worsens with dual task activities. At these levels of cognitive functioning, assistance with activities will be required. Repetition should be enforced to enhance learning, and frequent rest periods should be given. We want to provide the patient with closed-ended questions, such as, would you like to go for a walk or roll a ball? Therapists like to treat this patient with the compensatory approach and or the restorative approach. The goal of the compensatory approach is to find other means for achieving a task, while the goal of the restorative approach is to try to restore function in the affected part, thereby reducing the need for compensation. There's actually a study that shows bodyweight support treadmill training may be no more effective than traditional overground gait training in patients with mild to moderate impairments in gait and balance. Desired outcomes for these patients include increasing arousal or attention, increasing physical function, improving motor control, reducing and managing atypical muscle tone, improving postural control, improving transfers, improving or maintaining joint integrity and mobility. And we want to try to get the patient ambulating with or without assistive devices, and to increase gait speed and endurance. So, this is my favorite slide. Person-centered care is well established as the core foundation of the rehabilitative disciplines. With that said, we have to remove the idea of self when working with these patients in order to foster connection and rapport to create optimal outcomes. Having a TBI is literally as if the patient is reborn with a new mind, a new personality, a new identity. TBI patients act in a lot of ways almost exactly like a newborn. They can go from feeling euphoric to crying to very agitated and aggressive to very confused all in a short time. Oftentimes they're not able to control bodily functions like a baby. They don't know right from wrong. They see a new and terrifying world they see the world is a new and terrifying place, yet it comes with a vague familiarity of past broken memories, leaving the patient questioning if this new reality is even real at all. In this new frame of thinking, anything goes, and the inhibition of primitive thoughts and urges do not exist. The foundation of care is empathy. When treating this patient, you have to remember whatever anger, aggression, physical or verbal insults are thrown at you is not a reflection of who they are. It is a reflection of their disoriented thought pattern. It is an expression of having to accept this new identity and the terms of life that they now have to cope with. This This is a part of viewing the world through their eyes, understanding their disability, and being sensitive to the impact of trauma on their lives. Although a TBI patient is unable to communicate this, they have the subconscious desire for their therapist to acknowledge their trauma and be sensitive of the trauma on them, rather than just acting positive in hopes that they adopt your positivity too. A severely brain injured patient is just not able to cognitively comprehend the concept of positivity being expressed on them by another person anyways. Subconsciously, they want to be seen as the person they once were, as they are struggling with letting go of who they used to be. They're grieving for the loss of their pre-accident self and feel uncertain for their post-accident self. They knew who they aspired to be before the accident, but now they feel that will never happen. It's like an identity crisis. So it would benefit the treatment outcome if the therapist took the time in getting to know the patient for who they used to be, and before the injury, respected them and treated them with care, compassion, and dignity. The therapist should also take the time in getting to know the patient in the now. Doing this helps create better rapport and better connection. The patient is more likely to participate in treatment when you truly know how the patient is thinking. And adding to what I said before, don't just act positive, but actually create a positive connection. The therapist can do this by identifying the positives in the patient, translate these positives into goals, show a belief in their ability to accomplish these goals, and provide positive feedback. Show them the light at the end of the tunnel. The results of one study reveal new insights into therapeutic benefits of person-centered care. Positive relationship experiences through empathy, compassion, and understanding lead to better recovery outcomes, and it is central to the rehabilitation of a TBI. So now I'd like to present evidence on vagus nerve stimulation with traumatic brain injury. Here is a study that examines how vagus nerve stimulation delivered with motor training enhances recovery of function after a TBI. Vagus nerve stimulation, or VNS, has been used clinically to effectively treat many neurological disorders. Recent success in implementing short bursts of VNS paired with rehabilitative therapy has been shown to enhance motor recovery in animal models of stroke, thus leading researchers in this study to hypothesize that VNS would also be an effective tool to enhance functional recovery following a TBI. And indeed, the results of this study do support their hypothesis of pairing VNS with physical rehabilitation, and it actually enhances recovery of forelimb function and volitional pool strength following an experimental TBI. This is another study looking at enhancing rehabilitative therapies with VNS. The conclusion of this study shows VNS can indeed act to increase the gains benefited from rehab. This is a study that examines the wake-promoting effects of VNS in coma-induced TBI patients. These results actually suggest that VNS can promote wakefulness in rats with TBI-induced coma. So here I'd like to share a case study with you all. It's actually a real-life case study. I'm going to share pictures with you all, and I am actually very close with this family. I have permission from the mom and the son to share these pictures with you. So here it is. The patient is a 15-year-old male, significant for a severe traumatic brain injury resulting in cognitive and neurobehavioral sequelae. He was struck by a car traveling 35 miles an hour while crossing the road. He was unresponsive at the scene. Code blue on arrival to ER with a Glasgow Coma Scale score of 3. He was found to have a small left subdural hematoma, hemorrhagic axonal injury, and cerebral edema, as well as right humerus and clavicular fractures. MRI scan of the brain read as showing multiple foci of diffuse axonal injury involving subcortical and paraventricular white matter splenium of the corpus callosum, basal ganglia, thalamus, brainstem, and cerebellar hemispheres, with a left frontal parietal subdural hematoma. He was intubated and experienced a 16-day coma. After awakening and transferred to acute rehab, he presented with tremulous and ataxic motor skills, paresis on the right side with frontal executive dysfunction, including poor impulse control, perseverative on questions and instruction, and severe mood swings with agitation and aggression. So here he's in a coma with a Glasgow coma score of 3. We know this because he was only able to respond to painful stimuli by withdrawal and vocalizations. Here you can see the patient, or the therapist, is doing passive range of motion to ensure joint integrity and mobility and to prevent any contracture. And here, the patient's still in a coma. This patient was actually attempting, and another reason this was a Glasgow coma score of 3 is because the patient was actually attempting to pull out tubes due to discomfort. So they had to physically restrain the patient. And after awakening from the coma, as you can see, it's a team effort between all therapists when rehabilitating this patient. Here on the right picture, you can see that a therapist is supporting the patient in case they fall while they're sitting. Another therapist is actually holding the target so he can reach for it. On the left, you can see one therapist is helping the patient balance while the other therapist is giving verbal cues. And this patient is presenting with labile mood in this picture. Just before this picture was taken, he was happy to be he was euphoric for having his milkshake from the cafeteria. And out of nowhere, he just started bawling for no apparent reason. And this is normal for TBI patients. Here is a slide demonstrating great person-centered care. This is a nurse. You all may be thinking this is a little weird for a nurse to be this close and personal with the patient, but it's just a great demonstration of person-centered care, and it actually went a long, long way. The therapeutic benefits of person-centered care can actually be seen in this patient 13 years later. Here he is today. It is me. So it's me. I've come a long way. That on the picture on the right, that's me actually giving a full smile. I had paresis on the right side, so I couldn't make a smile. Questions and discussions? Thank you. Yeah.
Thank you for sharing your story. I was curious about the VNS. How were they stimulating the nerve? Studies that you had.
So the rat models, they did it invasively. They put it on I believe it was the vagus nerve that's along the jugular or the carotid artery. And I was thinking, that's kind of complex to try to use that in the clinic. It'd be weird just invasively attaching the VNS. But I thought about sharing another study that actually showed that transcutaneous VNS stimulation is already in use. And if this were to ever get into the clinical setting, we can actually provide transcutaneous VNS you can either apply it on the earlobe. There's a vagal nerve attachment here. You can put the transcutaneous nerve along the neck, and I believe there's even an area near the collarbone. Yeah.
Yes, well, my daughter was supposed to have it all these years, VNS, for her seizure disorder, and it's a little pacemaker, basically, just like a pacemaker, And yeah, the little, it wraps around your vagus nerve, and every time it goes off, which is every so many minutes, it kind of inhibits your ability to swallow, and it also, like if I'm talking right now and it goes off, it makes you, it makes your voice raspy when it's going off. So she couldn't tolerate that, but it's just right in your upper chest, you know. I don't know how many, every so many
Yes, Rob?
minutes it goes off.
What would you consider the normal intracranial pressure? Because that's the one of the pressure that's very important in acute care. So what would you say the normal intracranial pressure?
Normal intracranial pressure?
Mhm.
I did not find that in my research. I didn't provide that information in my
So that would
presentation.
be 20. When
20.
you're working in acute care, because you're the first therapist that will see your patient, so make sure the intracranial pressure is within those limits.
Okay.
And if it's higher than 20, you have to tell your medical team, your nurse or your medical team. It's very important, because if that goes up, the cerebral perfusion goes down. So there's not much blood. You want blood, you want it to heal.
Okay.
So if it goes up, make sure you tell your nurse right away, especially when you're working in the ICU units.
Yes, thank you for sharing that information. That would definitely be a part of checking the vitals
Yes.
and
Yes.
ensuring that the
Very
patient's medically
important.
stable. Thank you. Yeah, Matt?
Great presentation. Thank you for sharing that. It takes a lot of guts to get up and do that. We appreciate that. One thing that you really focused on was that patient-centered care and how much that meant to you. So my question for you is, you spend a lot of time on the hospital floors here with us and what we do. So as opposed to specifically for a TBI patient, but patients that are suffering from other ailments that we see more commonly here in this hospital, how can you apply, or what techniques have you seen that different therapists have done or that you have applied with the patients here to accomplish that patient-centered?
That's a great question. This slide can actually be applied to all patients, and as you all know, like we learned this in school, person-centered care is a very important part of our practice. I really believe in this slide, and I would love to implement that in my practice. But I feel like it was hard for me because this is my first long-term affiliation, my first inpatient setting. So trying to, gather all this new information and pay attention to the finer details kind of got in the way of me trying to really focus on person-centered care, but I did try my best. I saw great person-centered care in the therapists I worked with. I really like how Christina, she really connects with the patients, and she just has this way with neuro patients such as demented patients, and same with Laura, same with you. You even gave me advice on how we can really practice person-centered care. Yeah.
Well, I saw Macaulay have a good sense of humor with his patients, and good eye contact and a soft tone, caring tone.
And the reason why I'm so big on that slide is because, as you guys all know now, I was there. I was on the other side. I wasn't supposed to recover as well as I did. The doctors even gave me a poor prognosis because I was in a coma for longer than 2 weeks. And as I said in my slide, better recovery outcomes tend to occur in patients that were in a coma for less than a week. But what my healthcare team then think is why I recover so well is because of the insurmountable support system I had and the person-centered care that I received. And I know that whenever I'm with a patient, I feel like I can empathize with them and really connect with the patient because I kind of know what they're going through. I've been there. Yeah, Jim?
Great talk, by the way. I see many times with stroke patients and our traumatic brain patients that the nurses always have the television on constantly, I mean, throughout the entire day, is that a beneficial thing? Maybe I should throw that into speech therapy, or is that a distraction for the recovery?
Well, I think that throughout the day is nice. Just thinking back to when I was in the hospital, like I was in a caged bed, I was trapped, I didn't have a TV. And the thing about TBI patients, their thought pattern is disoriented, it's all over the place. And if they don't have some kind of stimulation, they're just gonna be in their heads, they're gonna be depressed, they're gonna go crazy basically. So I think having a TV to keep their minds distracted would help. But when it comes to treatment, it is very important to minimize the distractions.
Okay, so if, on that note, is there specifically something television-wise that they should be listening to? I mean, as opposed to Fox News versus
That's a really good question. I didn't look that up in my research. But now I do want to look it up. But I think there's a correlation out there. I'm not sure if anyone has done the research.
and speech.
Yeah, I'm a speech therapist. During treatment, I always, and this also goes sometimes for my patients with dementia, or strokes. I always turn off the TV. I usually always close the door. Always have the room well lit. And when you're doing therapy with them, because they're so distracted, I always just kind of stand in front of them really close, just so they can attend to you and listen to what you're saying, because otherwise they'll probably just be looking all over the place. And as far as the TV goes, I think it depends like where on their glaucoma scale they are. Because if they're really severe, sometimes having the darker room is better just for the brain recovery. So it really just kind of depends like where they are on the scale. And sometimes I will just, obviously depending on their cognitive functioning, sometimes I may just put like, not like a farm, but maybe something more like Marley and Me, or maybe that's like a little bit easier to understand, depending on their cognitive functioning, or not like a really, not like a movie where there's like a lot of dialogue where it's just gonna go over their head. It's something where they can maybe understand a little bit better.
I agree with that, because, like I said in my presentation, TBI patients are like newborns. It could be a 20-year-old, 25-year-old, 40. TBI basically resets their clock, their time clock. They act exactly like a newborn, and I think it would benefit the patient if they were watching something like you said that's easier on the mind, maybe like cartoons or Marley and Me, Pets, Dogs, something that is more on their new age, basically.
It wouldn't go, so it can be different, but sometimes also with the people with aphasia, like I would not put a cartoon with them because it could be a little, like I'm an adult, like I was a lawyer, why am I watching a cartoon? But maybe just something more real life, like Marley and Me, which is more, it's not necessarily a cartoon, but like an adult would watch it, but it's just like a lesser cognitive load for them to be able to understand it.
Okay.
Yeah.
Thank you.
How about music as opposed to television?
I would put music, so music really stimulates the right side of the brain, and like television would stimulate the left side, so those are all, music is definitely part of our brain. There's neurological patterns. I would definitely put on some music on there.
Regarding music, it's not a part of this presentation, but I actually read a study and I watched a documentary about how music can be therapeutically used to treat dementia patients. And I don't think there's other studies out there pertaining to any other neurological disorders, but I feel like it could have a similar effect. Dementia, the study showed that dementia patients, oftentimes they're, you all know that they're just not there. are lost, they are speaking confabulatory, they're confused. But in this documentary, this study, they put earbuds in their ears and listened to familiar music that they loved when they were younger. And it actually brought these dementia patients back to life, and they were acting more normal, they were able to speak clearer, more coherently. So I'm thinking, if you're gonna use music, definitely play something that patient, like in my slide I said, ask the family for familiar music that may be able to be used during therapy, so it might be able to help the patient concentrate better.
That was a good answer. That was what, if we're going for person-centered care, that is the first thing you have to ask the family. What was the person's favorite music? Because like what you said, there were studies, especially with dementia people, if you play like the music that they really like, somehow it just clicked and you will have that good response during therapy. So that was a good one. Good answer.
It's something to do with like stored memory.
Yep.
And it just brings that memory back, because
Yes.
music, sound is associated with good feeling and memories.
Yes.
So I can see how that works.
Yep.
Oh, it's funny, I was just thinking how people leave the TV and music on for their dogs when they go away, so it keeps their dogs calm, you know?
Yeah.
It's funny.
Good association. Any other questions?